All right, welcome. This is Chisel time with Dr. Aaron Huser. I wanted to call it karate time, but I don't know karate, so we went with chisel time instead because I do know about chisels, or what we call osteotomes. We're going to talk about MHE today. It's one of my favorite topics to talk about. I do serve on the medical advisory board of the MHE Research Foundation, and I'd also like to give a special shout out to Sarah Ziegler, who is by far one of the biggest advocates for patients with MHE. If you don't know her, you should. You should feel free to email her and talk to her because she's absolutely wonderful. All right, so we're going to start off with a little story, something I've learned after taking care of patients with MHE for a while, and that is when they tell you something, even though you may not see it, you may not feel it, they do, and it's probably there. And this is a young man who came in telling us he had elbow pain, couldn't see anything on the x-rays as we look right down there, look on this x-ray here. We get an MRI. And we're like, yeah, there looks like there's something right there that could be it. We couldn't really see it on this view. Get into surgery, and this is his ulnar nerve. It was lying right on that tumor right there. Absolutely something you should take out. It's impinging on his nerve, and that was a great lesson. That's all. It keeps being reinforced with every patient I work with MHE. So when you come to our clinic, and the first time we're meeting you, what I like to do is have a good conversation about how we treat MHE and our philosophy. I think a lot of parents who have children who have the mutation in EXT1 or EXT2 for the first time, it's very scary. I think for parents who have MHE and their child has MHE, it's less scary, but sometimes there's guilt that they feel, which I'd really like to tell them that you do not need to feel guilty about any of this. And what we strive, my partners and I strive to do when taking care of MHE is, one, we want to alleviate pain that any of our patients are having. Two, we want to make sure that none of their nerves are being compressed. We've had cases where kids come in and they can't move their foot up and down because they have a nerve compression. Patients will complain of burning or tingling in their fingers. Those are also signs of nerve compression. And then three, we want to make sure we save the joints in our growing children, and then treat joints that we need to treat in our adult children, or excuse me, our adults, so that they can go on to live a fulfilling life. After that, do a physical exam, see what's going on, and review their radiographs. Physical exams pretty much have them stand up, take a look at the patients, see if they have any bowing of their legs or knock knees, see if there's any of their ankles or their feet going out, look at their arms, take all their joints through a range of motion, hips, knees, ankles, wrists, shoulders, elbows, and then perform a sensory and motor exam where we're testing where the nerves innervate. Can they feel that? Is it normal? Do they have any tingling there? And are they strong? Are all their muscles working okay? And finally, push on those osteochondromas. It's probably the kid's least favorite part because sometimes they hurt, and those are the ones that need to come up. Then we'll look at the radiographs that we have. Usually get a standing one like you see here. And then we'll get any ones that we palpate an osteochondroma, we'll get an x-ray of that area, take a look at it. Other things we're concerned about, like the joints, we'll also get x-rays of those ones as well. So we're going to talk about three things now. We're going to talk about removing those osteochondromas. We're going to talk about what we can do to help with the joints and some of the research that's going on with that. And we're going to talk about nerve compressions too. Osteochondroma excision. This is a picture taken out from the inside of the knee. That's a big osteochondroma. These are the retractors we use. So I recently looked at all the patients we treated with MHE who are children over the past 5 to 7 years. And we've had over 109 pediatric patients. On average, their age was 10 years old, and we've removed 1,276 osteochondromas. I can tell you with certainty that number is over 1,300 now. And I just did this study about a week ago. So if we look closely, we see that most of them come from the knee. That's what the distal femur, that's the lower end of the thigh bone, and then the proximal tibia, that's the upper end of the shin bone. Those make the knee, and those are the most common places that we see osteochondromas. This number looks like it's about 375, and this one's about 150. So that's almost, it's 525 osteochondromas just from those two locations. The next most common ones we'll see are the scapula, which is your shoulder blade. So sometimes you can feel those osteochondromas rubbing against the ribs. The upper part of the arm, or the proximal humerus. The distal radius, which is this part of the wrist. And then your distal tibia, which is at the ankle, and your proximal femur, which is the top part by the hip. A lot of patients ask me, so how do you do this? It's not very high tech. Sometimes I feel like a sculptor. Once we get the osteochondroma, we put those retractors that I showed you around it. They look like little spoons, and they protect all the neurovascular structures that are in the way. Then we take a chisel, because it's chisel time, bam, and we knock the osteochondroma out, we smooth off those edges, and we then wash out the area. We put something called bone wax, which stops any of the bleeding. Little things that I think about with patients are that the most painful ones that I've seen are the ones that are on the front of the leg, either at the front of the hip or the front of the knee. And they can look really small on x-ray, but they tend to be pretty painful. Actually, don't have one, but it'd be right over here on the knee. And then ideally, we like to remove them when they're older, because osteochondromas don't necessarily recur. If we remove it, it's gone. But because the problem is near the growth plate, they can grow from the growth plate, and they come back, even though they're not the same osteochondroma. As Sarah Ziegler, who I mentioned earlier, would say that you're having additional growth. It's not a recurrence of the same one, it's a new osteochondroma. And one of the big points that I've really liked, that I've developed over time, is that when we start operating on the distal femur, let's remove all the osteochondromas that are there instead of just removing one. Because you're going to go to the operating room, let's remove the ones on the outside, the inside, and the back of the knee, so that's totally cleaned up. And hopefully we take away all the symptoms that they're causing. This is just an example of before surgery and then intra-op after we've removed them all. So next up is saving the joints. This is a picture of a young man with a dislocated radiocapitellar joint or elbow joint. This is one of the worst complications of MHE, and we'll talk about that a little bit more. First, we're going to talk about the hips. So what we look for in the hips. Here's something called what we call coxa valga, which means that the femoral neck is almost vertical, and it should sort of be in this orientation and more horizontal. And you can also see that the cup, which is right here, is a little shallow as well, and it leaves that head uncovered. And so some things that this can cause, it can cause groin pain. There are also osteochondromas on the neck of the femur. So this is the ball, this is the cup, and then this is the neck. And those osteochondromas on the neck can actually impinge on your cup and cause pain. The other thing that can happen is that you have what we call ischiofemoral impingement. So your sit bone, if you push in the back of your butt, there's a bone there. That's your ischium, and this is the inferior neck, and this young person has osteochondromas there, and then actually can squeeze anything that goes through that space, which can be pretty painful too. Recent literature has shown that there is patients with both, and actually the ischiofemoral impingement, which is the second one I talked about, that's more common in patients with MHE than the public. And then they also have dysplasia. So what do we do? Well, the treatment is to tip that head back in the cup, remove the osteochondromas from the neck, and then also potentially in the future reorient the cup over so that we get good coverage of the femoral head. And that's what these are: resection of osteochondromas off the neck. Sometimes you need to do a surgical hip dislocation to do that. Varus osteotomy, that's what this is showing. And then the triple or PAO is where we cut the pelvis to move that over. And that's really to help preserve the hip so that maybe we can prevent the need for total hip replacement at a younger age. Next up, the knees. It's pretty basic stuff here. When you have MHE, you sometimes develop knock knees or bow legs. This young person has an example of knock knees on this side of the body. If you draw a line from the femoral head down to the ankle, you see that line is on the outside. You know what? We got the smart TV. Let's see. So that should be in the center. It wasn't as straight as I'd like it, but that's okay. Okay. what we'll see when we're doing our standing examination, we'll see those children with knock knees. Knock knees can be normal in patients, usually up to 7 or 8 years old. That's with patients with or without MHE. But we do see it more often in patients with MHE, and we believe that has something to do with the osteochondromas that are located near those growth plates. This patient, we use something called guided growth, where we don't need to break the bone. We put a plate and 2 screws in, and that realigns them. You can see how much straighter it is than it was preoperatively. Now, if you're an adult and you have this knock knees or bow legs, and you start having pain around your knee, we actually have to cut the bone, and that's what an osteotomy is called. Again, we use the osteotome to do that. And then the ankles. So what we look for in ankles is the ankle going out, ankle valgus, and that can be caused from a couple things. Sometimes this bone can grow so that it goes out. Sometimes this bone, the short bone, which is called your fibula, the big bone is your tibia, because of osteochondroma growth, it gets pulled up, and it should actually be lower. And when it's lower, it acts as a buttress. It pushes, it keeps that ankle or the foot in place. But as it grows up, the foot starts to slide out. And so that also causes a problem. Pretty good research that was done back in 2002 out of JPO showed that in their study of adults who had MHE, about 19% had evidence of arthritis, and that the change in the angles of the knee was actually higher in those with arthritis than weren't, which says we should do something about that. This newer study out in 2021 looked at a couple different things. They looked at the length of the fibula, the small bone, to the length of the tibia, which is the shin bone or the larger bone. They looked at this angle down here, which is sort of that angulation I was talking about. And they found that those were significant for patients who had the length, the osteochondromas up here were all significant in how that ankle was forming out. And so these are all things that we think, okay, if this is the problem, how can we treat these? And so the treatment for the ankle that we use, here's an example of someone, you see this wide space here. Ankle is going out to the side. The fibula is higher. This is a growth plate, these clear things. So this is a joint, and then this smaller line is a growth plate. That growth plate should be at the level of the joint. In this patient, we did an osteotomy. We cut the bone, we turned it, and we straightened them out. Closed down that clear space, helped stabilize the ankle, nice straight up and down and well aligned. There are different options. One that we've been trying is actually closing this growth plate when we do that, because you don't want this to come back. And so that may, if you close the growth plate, then you may have to lengthen the leg down the road. You know, we do a ton of lengthening here at the Paley Institute. It's not a small thing to do lengthening, but it's something to consider as opposed to having to redo an osteotomy for deformity correction. All right, the elbow. And this is the one where really we've been huge advocates. I've been part of a couple research studies looking at the elbow. So what we look at here is we're concerned about patients having pain over the outside of their elbow, which is right here. It's called the radiocapitellar joint. And that can get pushed out. Patients can dislocate that due to this, what we think is the bone. I'll show you some research on why we think that. It also may be related to the osteochondromas around here, because it causes the ulna to become shorter. And we look for patients, the motion of that joint is this, what we call pronation, supination, so palm up and palm down. And so we look for loss of motion, we look for pain over that radiocapitellar joint that I was talking about, and just a bowing appearance of the arm you can sometimes see. And then we look for a bunch of things like the bow here, the shortness of the ulna. We look for that joint to become subluxated on our x-rays. In 2002, the same group that published the other study about the ankle also published about the elbows, and essentially 61% of patients had no limitations of activities or pain based on their elbows. But the remaining 39% had some problem. I would challenge anyone who would say that they're okay with letting their child's elbow dislocate. I don't think anyone would say that, no matter who they are. And our goal here has been to prevent that and prophylactically treat that. And so we published an article in 2021 that gives us a nice chart where we take the length of the ulna and the bow of the ulna, and we can plot your patient on this chart. This is available for everyone. It's online. And it tells us this line here is whether they're at risk for subluxation or dislocation. And that's what we determine, say, hey, we think we should do something to try to prevent this from happening. So then I looked at the patients we've done this for. And the orange dots are the ones where this is before surgery. The blue dots are the ones that have had surgery. So we've actually, by doing this surgery where we cut the bone, we straighten out the ulna, we put this nice little plate on, we've been able to push these patients further away from this line, which is the one that sort of says you're in danger of dislocating your elbow. So far, none of those patients have dislocated, low complication rate, and we're just hoping that we keep following their progress and see that we've prevented dislocations. It would be really great. So again, the treatment, we cut the bone, remove osteochondromas, we fix the bone. There's a lot of studies about lengthening. We're trying to prevent the need for lengthening because you have to use an external fixer to do that. No one likes an X-fix. And then this is an example of an elbow that is dislocated, and there aren't really great solutions for that once it comes out. And that's why we think prevention is the #1 thing to do. All right. Now the wrist. There are two big things that can happen at the wrist. One, your ulna can be longer than your radius. So remember, the ulna is the outside bone, radius is the big bone here. It's confusing because you can turn your arm over. When you have overgrowth of your ulna compared to your radius, you can dislocate that joint, and that can be painful. And the opposite is also true. When your ulna doesn't grow enough, you can actually get a tilting of the radius, which can cause loss of grip strength and pain as well. And so that's what we look at when we're examining the wrist. A recent study that came out showed that we can actually do guided growth like we did on the knee, where we don't have to cut the bone, to help treat the deformity in the wrist. This is an example of an adult. So for that person, we actually need to put a plate and do that correction, what we call acutely, because they have no growth plate that we can use, and we bring it down. For the wrist that's too high, you can actually close that growth plate there, and the radius will grow and reestablish the normal relationship, or you can shorten the ulna a little bit so it brings it down and stops impinging there. So those are really the two options for that. Always osteochondromal excision. If you're going to go there, our philosophy is take those osteochondromas out. Okay, lastly, nerve compressions. This is a great example. This is the fibula, which is by the knee. It's the small bone, and there's an osteochondroma growing on both sides and it's sort of choking off this nerve. And that's really something that is very important in these kids and adults with MHE, is looking out for these nerve impingement signs. So in general, patients will say, and these are like what the kids say, I feel like I have ants on my feet, or my hand falls asleep. I get the tinglies. It feels like I'm on fire. Adult patients are a little bit more descriptive. I have burning or I have tingling in my fingers. And this is the x-ray of a patient. And this is what the MRI looks. The nerve is right there, and it's surrounded by these two osteochondromas. And then you got another one coming up here, and it's wrapped around it. So that's painful. And you need to take those out with care so that you don't cause problems with the nerve. It's important to test. This is the peroneal nerve. That's that first one. That's responsible for dorsiflexing, or moving your ankle towards your head, and moving your big toe towards your head. The ulnar nerve, which is the first one I showed way at the beginning, is right here. That's responsible for sensation in your little and ring finger, as well as spreading your fingers out. Median nerve, which can be decompress it here at the wrist. It's like a carpal tunnel. And then tibial nerve down by the ankle on the inside can be compressed. We've also had patients with sciatic nerve. The sciatic nerve comes from the back of your thigh bone and actually splits into the tibial and peroneal nerve. But this patient had a big osteochondroma on the back of her thigh, and they had a surgery, and they woke up and they couldn't straighten their foot out after a surgery. That was not related to their osteochondroma. It's just because she was laying on her back for the duration of the surgery, which was probably an hour and a half. So we actually had to go in there and remove that one. MRI is really helpful. One thing I haven't said in this presentation is we tend to get MRIs of all our spines just to make sure we're not missing any osteochondromas within the spine. And then we have a very low threshold to get in there alleviate the nerve from being pushed on. Patients feel so much better if they have it, and you're preventing a bad complication, which is nerve palsy. This study out of Texas Scottish Rite, they just sort of looked at their removing osteochondromas from the proximal fibula, which is the one I just showed you, for the peroneal nerve. They had fairly good results with that. So I will keep going over this because it is absolutely the most important lesson I've learned in caring for patients with MHE is they will tell you exactly what's going on. If you push on an osteochondroma that hurts, even though you think it might, and they say no, it probably doesn't hurt. But if you push somewhere and you're like, I don't feel anything, like, no, I have pain there, it's there. And we need to listen to them. Parents, friends, physicians. So take home point number 3, same thing, listen to them again. That's right, that's the most important point. 1, 2, and 3 is listen to what they're saying because they're telling you what's going on. And then take home points 4, 5, 6, be on the lookout for nerve compressions, prevent joint dislocations and subluxations, and we can help these patients. I think people need to listen to them. Probably one of my favorite stories is there's a young woman that came in who is on narcotic medication, some psychiatric medications, and took out her osteochondromas, decompressing her nerves, actually got her off that stuff. She felt so much better, but she wasn't being listened to. And that's a real shame when it comes to taking care of patients with this disease. So thank you for paying attention. I hope you had a good time. I'll show you some more karate moves some other time. Feel free to email me at ahuser@paleyinstitute.org. Thank you very much.